There are some things that local pulmonologists and others who deal with pulmonary disease might want to know so that they don't always feel that they have to completely rely on an academic center or a larger institution.
Yes, often the diagnosis of hypersensitivity can be made with a high degree of confidence if you know how to take an occupational and exposure history and how to go about a basic diagnostic workup. In regards to the former, occupational and home exposures include querying the patient about exposures to birds or bird proteins or bird products. Hot tubs wasn't highlighted in the session, but is another one that we often query our patients for, and exposure to molds. And for patients who do farming activities, an assessment of the nature of their work as well. We don't see as many farmers in day-to-day practice, but that's something to be aware of for local or community physicians. In regards to an evaluation, getting the occupational or exposure history will prompt you to consider a diagnosis of hypersensitivity, but to establish the diagnosis, you need to get imaging that has features that are consistent with the disease, and at a basic level get a bronchoalveolar lavage in patients who are stable enough to go for bronchoscopy, in which you should see a lymphocytosis. And if you don't see lymphocytosis, we highlighted that it's very, very unlikely that a patient would have hypersensitivity pneumonitis if the bronchoscopy was done with a patient not on immunosuppression or not on corticosteroids at that time. It's not often that patients have to go for a biopsy, a surgical biopsy, but sometimes the diagnosis, even after imaging and after a full clinical evaluation, is not clear, in which case a biopsy is helpful and can help solidify the diagnosis or rule out the diagnosis.
Now, if a pulmonologist orders a biopsy, I recall that you said that it's very important they do one thing.
I had strong opinions about this, yes. That you ask the surgeon to please obtain samples in all three lobes, upper, or all three zones, I should say, whether it's on the right or the left, the upper, middle, and lower.
So could you talk to our more local pulmonologists about things that they need to know in order to accurately diagnose and feel confident that they're doing a good job of that, and then maybe treat the condition as well?
Well, the first line of treatment or management of patients who have hypersensitivity pneumonitis is antigen abatement, or said another way, removing the patient from exposure to the antigen that's causing or is thought to cause hypersensitivity pneumonitis. After that, corticosteroids, systemic corticosteroids are the mainstay of treatment. Long-term corticosteroid treatment is associated with side effects for most patients, so that's not ideal. But for patients who are recovering from an episode of hypersensitivity pneumonitis, or as they're undergoing a change in their environment, corticosteroids are often used to symptomatically make them feel better, although lung function also tends to improve with it. But even in patients who are not on immunosuppression, very often if they can remove themselves from the antigen, they will get better. The exception to that would be patients who have fibrotic lung disease, where fibrosis is an irreversible event. But if you can prevent patients from having progressive disease by removing them from the antigen, that's also still recommended.